Good morning. It's Saturday, February 22nd, 2020. Lots of twos in today's date. Interesting. Anyway, so we have dehydration on the schedule today in the Goodman text and review of the research chapter in the Blue Book. So let's start out with the reading.
Introduction to metabolism. As noted earlier, the endocrine system works with the nervous system to regulate and integrate the body's metabolic activities. The rate of metabolism can be by exercise, elevated body temperature, for example, high fever, hormonal activity, for example, thyroxine, insulin, epinephrine, and specific dynamic action that occurs after ingestion of a meal. All metabolic functions require proper fluid and acid-base balance. Although acid-base metabolism is not in itself a sign or a symptom, the consequences of an acid-base metabolism disorder can result in many clinical signs and symptoms. Therapists are unlikely to evaluate someone with a primary musculoskeletal lesion that reflects an underlying metabolic disorder. However, many inpatients in hospitals and some outpatients may be affected by disturbances in acid-base metabolism and other specific metabolic disorders. Only those conditions that are likely to be encountered by a therapist are included in this text. Fluid imbalance is fluid deficit. Dehydration. Fluid deficit can occur as a result of two primary types of imbalance. There is either a loss of water without loss of solutes or a loss of both water and solutes. The loss of body water without solutes results in the excess concentration of body solutes within the interstitial and intravascular compartments. To preserve equilibrium, water will then be forced to shift by osmosis from inside cells to these outside compartments. If this state persists, large amounts of body water will be shifted and excreted, osmotic diuresis, and severe cellular dehydration will result. This type of imbalance can occur as a result of several conditions: decreased water intake, for example, and availability, unconsciousness, water loss without proportionate solute loss, for example, prolonged hyperventilation, DI, increased solute intake without proportionate water intake, tube feeding, excess accumulation of solutes, for example, high glucose levels such as in DM. The second type of fluid imbalance results from a loss of both water and solutes. Causes of the loss of both water and solutes include hemorrhage, profuse perspiration, for example, marathon runners, and loss of GI tract secretions, for example, vomiting, diarrhea, draining fistulas, ileostomy. Post-surgical patients who have had a joint replacement, hip fracture, multiple traumas, or neurosurgery often, one of three. Lose blood and become hypovolemic despite efforts to maintain their homeostasis through blood transfusion and fluid replacement. Severe loss of water or solutes, or both, can lead to dehydration and hypovolemic shock. It is important for the therapist to be aware of possible fluid loss or water shift in any client who is already compromised by advanced age or by a situation, such as an ileostomy or tracheostomy, which results in a continuous loss of fluid. Because the response to fluid loss is highly individual, it is important to recognize the early clinical symptoms and to carefully monitor vital signs in clients who are at risk, especially the elderly, the very young, or the chronically ill. 65 athletes and normal adults may experience orthostatic hypotension when slightly dehydrated, especially when intense exercise increases the core body temperature. The normal vascular system can accommodate this effectively. Fluid excess can occur in two major forms: water intoxication excess of water without an excess of solutes, or edema, excess of both solutes and water. Because the etiologic complex, symptoms, and outcomes related to these problems are substantially different, these fluid imbalances are discussed separately. Water intoxication, resulting in hyponatremia, is an excess of extracellular water in relationship to solutes. The extracellular fluid, ECF, becomes diluted, and water must then move into cells to equalize solute concentration on both sides of the cell membrane. High water consumption without solute replacement can result in hyponatremia, a potentially lethal situation. Water excess can be caused by an accumulation of solute-free fluid. An increase in solute-free fluid usually occurs because of excess ADH, tumors, endocrine disorders, or intake of large amounts of only tap water without balanced solute ingestion. The latter situation occurs most often in older adults who drink additional water after having the flu, with its associated vomiting and diarrhea, or in athletes who have lost a large amount of body fluid during exercise that has been replaced with only water. Symptoms of water intoxication are largely neurologic because of the shifting of water into the brain tissue and resultant dilution of sodium in the vascular space. 2 of 3.
Okay, so that is the reading, the Goodman edition. I think I have the 6th edition, I think. Anyway, and then we have some from the Goodman text. We also have some tables. Clinical signs and symptoms of dehydration. Mild dehydration would be thirst, dry mouth, dry lips. So if you see patients licking their lips, doing that, chances are they're dehydrated. Moderate signs, very dry mouth, cracked lips, sunken eyes, sunken fontanelle in infants, poor skin, turgor, figure 4-4. I need to find that one. Let's see if we can find it. Goodman text. I think that is in differential diagnosis. Goodman text. See if we can find figure 4-4. Figure 11-8. That's definitely not it. Let's see, let's go here and go figure 4-4. See what it pulls up. No match. Let's go back. So sometimes it's different because I have a different edition. So let's see. Let's go to chapter 4. Figure 4-1. Figure 4-2, figure 4-3, and figure, okay, here we go. Figure 4-4. So the skin test, yes, and a lot of times I will actually do that on their hand. So let's go ahead and we'll put that in our There you go. Let's see. I need to go get my water. Oops. Talk about dehydration, right? Caffeine can dehydrate you. Come on now. So if you drink caffeine, it's probably a good idea to drink water to counteract all that. Anyway, so moderate is very dry mouth, cracked lips, sunken eyes, sunken fontanelle in infants, poor skin turgor, which here's the little figure over here that we went and found, postural hypotension. So when they sit up, their blood pressure goes down. When they stand up, their blood pressure goes down. If you have a patient like that, you might want to also check for dehydration. Severe dehydration, all signs of moderate dehydration, plus rapid weak pulse, more than 100 beats per minute at rest, rapid breathing, confusion, lethargy, irritability, cold hands and feet, unable to cry or urinate. Clinical signs and symptoms, dehydration or fluid loss. Early clinical signs and symptoms are going to be thirst and weight loss. As the condition worsens, other symptoms may include the following: poor skin turgor, dryness of the mouth, throat, and face, absence of sweat, increased body temperature, low urine output, postural hypotension, increased heart rate by 10 beats a minute, decreased systolic or diastolic blood pressure by 20 when moving from a supine to a sitting position, dizziness when standing, confusion, and increased hematocrit. Water intoxication. Wow. I'm sure we don't have too much of this. Decreased mental alertness. Other occupying symptoms of sleepiness, anorexia, poor motor coordination, confusion. Any severe imbalance, other symptoms may include the following: convulsions, sudden weight gain, hyperventilation, warm, moist skin, signs of increased intracerebral pressure, slow pulse, increased systolic blood pressure, more than 10, decreased diastolic blood pressure, increased systolic, decreased diastolic. That right there is a red flag. Decreased diastolic blood pressure, mild peripheral edema, low serum sodium, and low hematocrit. So those are the tables from the Goodman text along with the reading. And then the blue book was going over some research and evidence-based practice. This was the top of the article. It wasn't complete, so I'm assuming that's not really where we're supposed to start our reading. So we'll go to the next slide. Double-blind test. A form of control and randomization of an experiment. in which neither the experimenter nor the subject knows who is actually receiving a treatment. For example, to test medications, similar looking pills, some with the drug, some containing a placebo, are numbered. Neither the experimenter or the subject knows who is actually receiving the medication or the placebo. The data are analyzed to determine if the drug had any effect or if there were any beneficial effects from the placebo. Standard deviation measures the variability of the study. The bigger the deviation, the more variable the set of scores or data from the study. The standard deviation is a type of average of these deviations that provides an overall picture or measure of the study's variability. Let's get this off of here. There we go. Statistical significance refers to the probability or level of confidence as to whether or not the results of the experiment happened by chance. P-values are often set at 0.05 or 0.01. This means that a P equals 0.05. There is a probability that the result obtained would occur by chance 5% of the time and would occur from the treatment or procedure performed 95% of the time. A p-value of 0.01 is a higher statistical significance because there is only a 1% probability that the results of the study occurred by chance. Evidence-based practice integrates patient wishes and values and the clinical expertise and experience with the best research evidence available. The patient's expectations, desires, and concerns are integrated into clinical decision-making regarding therapy or intervention. The expertise of the clinician makes use of past experiences and skill level to rapidly and accurately diagnose and assess the benefits or risks of potential interventions while taking into consideration the patient's values. This research means the latest clinically relevant evidence which considers precision of diagnostic tests, power of prognostic studies, and safety and efficacy of therapeutic or preventative interventions. New, better evidence invalidates previous accepted tests or interventions. B. Framing questions that are answerable and clinically relevant. Background questions ask for general information about a condition or disorder, biological, sociological, or psychological. Foreground questions ask about a particular patient's status with the disorder, intervention, and clinical outcomes. Evidence databases. Avoid traditional textbooks and journals for making ultimate decisions. Use online evidence-based services or evidence-based journals to ask your questions. Examples are Medline, Cochrane Library, Pediaro, and several others. There. D. Assessing the evidence. Which evidence best answers the questions posed? The validity of the evidence is ranked. Levels of clinical evidence by rank. The highest rank is going to be systematic reviews and meta-analysis, which is the combined results of many studies. The next level after that would be randomized, double-blind controlled trials. The next level after that would be cohort studies. It compares groups of interest, for example, smokers versus non-smokers. And the level under that is case studies of various formats. Under that is ideas, editorials, and expert opinions. We won't even talk about animal research. Evidence-based practice with diagnostic or screening test. Does the evidence show that a particular diagnostic test is accurate? Is there a gold standard? Is the test valid for the patient condition in question? Does the test have high sensitivity, such as a negative result will rule out, snout, the condition, or a high specificity where the positive result rules in, spin, the condition? Likelihood ratios are more statistically powerful than sensitivity or I hate saying that word. Specificity. Very high likelihood ratios, 10 or more, rule in the diagnosis. Ratios of 0.1 or less rule out the diagnosis. Anything in between is inconclusive. Evidence-based practice with prognosis and intervention. A similar process of asking questions, searching the databases, and making critical assessments is used to determine best prognosis and intervention. With intervention, likelihood of help versus harm can be determined, as well as risk reduction and outcomes. Then the article or the PDF gives recommended references. I'm assuming that this is recommended references for studying for the Npte. So what I did is I went through my library, show you my beautiful library that I'm so proud of. Yes, that is my library. When I first started the program, I was using Chegg, and I bought my Atlas of Human Anatomy, and I bought my Netter's Clinical Anatomy, and I bought the other one. I can't remember what it's called. It's not Netter's, it's another one. I think I have it somewhere. Oh, here we go. More Clinical Oriented Anatomy here. And I ended up not liking Chegg, and I liked the Kindle better. So I rebought my Netter's and my Moore's. And the only book that I did not rebuy was my exercise physiology book. And that particular book was not available on Kindle on Amazon. So back to the books. So I snipped out the books that I have, and I put a black mark next to the references. So on this page I have 4. Guide to Evidence-Based Physical Therapist Practice, Pharmacology and Rehabilitation, Pathology, and Differential Diagnosis for Physical Therapists. And then I went and I found the other books that I don't have. This one I totally want. PNF in Practice. I'm getting this book because I use PNF when I work. When you work in the skilled nursing facility, I should probably not say this on tape, but You get paid more when you use neuromuscular re-education, when you use that treatment code. And a lot of what we do as physical therapists can be coded as neuromuscular re-education if you know what to do and how to word it in your documentation. So I use a lot of neuromuscular re-ed. I do not charge therapeutic exercise very often. In my opinion, I think if you're doing stretching and strengthening, you can charge therapeutic exercise. But a lot of times what people are doing is not strengthening their neuromuscular re-educating the muscle. Strength protocols are usually 3 sets of 10, 3 sets of 8, 3 sets of 6. In a lot of the skilled nursing facilities, the patient population is not appropriate for that type of training. So in the skilled nursing facilities, the only time I ever really charge therapeutic exercise is when I'm stretching a patient. And a lot of times I will actually put that under manual, because if my hands are on the patient, it's manual therapy. So I very rarely use therapeutic exercise. It doesn't pay much, and the management really likes you to use manual if your hands are on the patient. Neuromuscular re-education, if you're doing, if you're doing 20 reps of an exercise, are you strengthening? Probably not. You're mostly re-educating the brain. I had my thought process kind of went for a second. Okay, yeah. So the only time I ever really use therapeutic exercise is when I'm giving a home exercise program. Or as I like to call it, a room exercise program. I'm always giving patients room exercises to do, and that would be appropriate to put under therapeutic exercise. Or you could also even put it under education. It just depends on what you're actually doing. Okay, so I really want that book. I'm going to get that book, PNF in Practice. And I like the pictures. Look at that picture. It actually is showing, let me go to slideshow so I can make it bigger. So the therapist is saying, pull your leg up. It's telling you in little, I don't know what you call these little circle things, but it's saying, pull your leg up. Let me pull your leg back slowly. Don't let your leg be pulled down. Try to hold it in position. Stay in this position. Don't make any movements. So I really like this part, and I went through the book a little bit. So this is definitely a book I'm going to get, and I kind of, let's see. I think I put on how much it is, but it's not really expensive actually. But I'm definitely going to get that book. Add it to my Kindle library that I am so proud of. Okay, the next one I don't have is Wound Care Essentials Practice Principles. So we do have a couple of wound care books that we were asked to obtain. Let's see if I can find them. Right here. Wound Diagnosis and Treatment. Texan Atlas of Wound Diagnosis and Treatment. So that's the only wound book that I have. So I don't know if I need it. I'm not like super into wounds, but I need to know it to pass the Npte. So we'll see if that one book will give me what I need. Campbell's Physical Therapy for Children. Kindle is $93, and the pediatric books I have is Peds Rehab Notes here. and the Clinical Practice Pediatric Physical Therapy. Those are the two peds books that I have. So we'll see as we get further on into the Final Frontier course if that's going to be adequate or not. Physical Agents Theory and Practice, talking about modalities. My modality book is, let's see if I can find it right here. Modalities Therapeutic Intervention. That's the only modality book that I have, so we'll see if that's enough. But to buy it, it's $56 on Kindle. Orthopedic Physical Therapy. That might be a good one. What do I have in my library? Let's see what I have. There's Dutton's Orthopedic Examination, Evaluation, and Intervention. That might be adequate. Here's Orthopedic Examination Test. Let's see what else I have. Yep, those two books. So Cook and Dutton. Cook, I really like him on Medline, Medbridge. I like his videos. Is really good. And then let's see here. We have Physical Therapy Documentation, From Examination to Outcome. That might be actually a pretty good book. To buy it is probably $65. The documentation, books that we were asked to buy during our class, our course, was this one, Documentation for Physical Therapist Practice. Let's see, and I know we had one more somewhere. Oh, Writing Patient Client Notes, right here. It doesn't really give me a picture of the front page. Let's see. Here we go. Well, sort of. Inside front cover. Ensuring accuracy and documentation. So that's the one that we were asked to get, these two here. I like this one because it's from examination to outcome. So outcome measures. That might be really good reading right there. Okay, and then on this one, I had the Essentials in Cardiopulmonary Physical Therapy book. I had the Muscle Testing and Function. I had the Therapeutic Exercise Foundation and Techniques. And I recently bought the Orthopedic Physical Assessment, Maggie. So, the ones that I did not have was Management of Common Musculoskeletal Disorders. That might be a good one. $85. Muscle Testing ebook, Techniques of Manual Examination and Performance Testing. I already have a muscle testing book. This one right here, Muscles Testing and Function. So I don't know why I would need another one. Not on Amazon was the Cardiopulmonary Physical Therapy book by Mosby. That was not on there. The cardiopulmonary book that I do have is this one, Cardiopulmonary Physical Therapy, Essentials of. So that might be adequate. The other one they didn't have on Amazon is Wound Healing, Alternatives, and Management. Another one I didn't have is Joint Structure and Function, a comprehensive analysis. That might be interesting to read. $74. Here's another PEDS book, Handbook of Pediatric Physical Therapy. And the last one, exercise physiology, energy, nutrition, and human performance. Like I said before, the Chegg, it was my first term of PT school, and I was using Chegg and Kindle, and I really like Amazon Kindle a lot better than Chegg, and so I never reordered. Actually, I tried to, but it wasn't available in Kindle. But this one is exercise physiology. It is available in Kindle, so if I need it, I might rebuy that. And then on the last page here, I have the modalities. I have the physical rehabilitation book. I love this book. And the motor control, I have that one. So the books I don't have is Foundations of Clinical Research. The research book, that it was my first term, and I don't remember what happened to that book. But this, I think it's actually a hard book that I had to buy, because Amazon and Chegg didn't have it, I think. But Foundations of Clinical Research, this is an e-textbook. I hate hard copy books. I love my ebooks. Love, love, love my ebooks. A Rehabilitation Specialist Handbook Kindle is $79. Prosthetics and Orthotics, Lower Limb and Spinal is not on Amazon. Teaching and Learning for Physical Therapist, $56. That might be interesting. This is the other book I want to get. I want to first get that PNF book, and then I want to get this book. Totally want to get this book. Netter's Concise Orthopedic Anatomy ebook. I looked into it. Look inside. You can look inside the book. And I looked inside, and I was like, oh my gosh, I need that book. So those two will be added to my library eventually. The Concise Orthopedic Anatomy, as well as, where's that PNF book? This one, the PNF book. Probably add this one first, because I will actually probably use that. I love ebooks because I have it on my phone, my iPhone, and when I'm treating a patient and I forget about something, I can go to the search engine. I can find stuff really, really fast. And so I have my Dropbox on my phone. So I keep all my Dropbox stuff. Love my Dropbox. Love, love, love. So I can get to stuff really, really quick when I'm treating patients, and I just love it. So anyway, that is it for today on the Final Frontier on February 22nd, 2020, Saturday. Dehydration, review of the research chapter in the Blue Book. And so that's it for today. We will stop this recording. Thanks for studying with me.